Thalassemia Care Continuum, Prevention, Advanced Management and Policy Readiness. This conversation goes beyond clinical care. It is a public health and social responsibility that impacts thousands of families across India. Thalassemia demands a continuum of care, from prevention, screening and early diagnosis to advanced treatment and lifelong management. While medical progress has been significant, challenges around awareness, access and affordability, and safe blood transfusion remains very real. And when we talk about globally, innovation is accelerating with recent FDA approval of the first oral drug for thalassemia in USA, which offers a new hope and new questions around access and policy readiness in countries like India. And now I would like to take this opportunity to this timely and deeply important discussion led by the stalwarts of thalassemia care of our country as we reflect on how to move from intent to impact of thalassemia care. Now I would like to invite on stage our moderator for the discussion, Dr. Manas Kalera, Senior Consultant, Pediatric Hematology, Oncology and BMT at Sir Gangaram Hospital, New Delhi. Dr. Vinita Srivastava, National Health Authority, Ministry of Health and Family Welfare, Government of India. Let's welcome our speakers with a round of applause. Mrs. Shobha Tuli, Secretary, Thalassemics India and President, Federation of Indian Thalassemics. Dr. Sangeeta Pahuja Sindhavani, Director, Professor and Head of Department, Immunohematology and Blood Transfusion, Lady Hardinge Medical College, New Delhi. Dr. Dinesh Pendulkar, Director, Sarvodaya Cancer Institute, Sarvodaya Hospital, Faridabad. Dr. Ritika Sach, Professor of Medicine at Lady Hardinge Medical College, New Delhi. Let's have a round of applause for our speakers. Over to you, sir.
Hello. So very good afternoon to the audience here. And it's indeed a proud privilege for all of us to be here on this winter afternoon in New Delhi, where we are here to talk about a disease called thalassemia. So I was about to ask, ma'am, at the onset, that how many of you have heard the name of thalassemia? And then I realized there was a quiz and people were actually giving good answers. So definitely you must have heard about thalassemia. I want to know if there is anybody who has not heard of thalassemia. Is there anyone who has not heard of thalassemia? So I guess everybody has heard about thalassemia. So that's a good start because that makes our interaction with you more meaningful. So just to give you a brief overview, this is a genetic blood disorder where if you have a thalassemia major form, which is the most extreme form, you require blood transfusion for the rest of your life. Every month, we have to give blood transfusion to this patient. Why? Because their blood formation is there, but this blood breaks down. And this blood is not very good quality. It breaks down. The patient becomes anemic and he develops all symptoms of anemia. So you keep giving them blood. And why is a child born of thalassemia major? Because the parents had thalassemia minor and somehow that was not detected during pregnancy. So this is a preventable disorder. If you identify that a mother is thalassemia minor or is a thalassemia carrier, you immediately do the testing of the father. If the father also has thalassemia minor, you quickly check the baby in the tummy by doing a testing, an invasive testing, and you can find out whether the baby has thalassemia major or not. So as a rule, we all should know about our thalassemia status. I think that is what is most important message, and especially those who are going to get married, who are going to have babies. They have to plan their life. They want a healthy child, and we want that you all screen for thalassemia. And today our discussion is going to be around this disorder. And why discussing this disorder? Because despite all the awareness, every year 10,000 children are born with thalassemia major. And imagine that a child who is thalassemia major from 6 months onwards requires 1 unit of blood transfusion. And as he or she grows old, they may need 4 units of blood every month to sustain a good life. You can cure them by doing a bone marrow transplant. But again, for bone marrow transplant, you have to find a good donor. You have to do chemotherapy for this patient, do a transplant. Transplant carries its own risk. So why to make a child suffer? And if at all a child is born with thalassemia major, how do we give them a good quality of life? And that all is possible, and our esteemed panelists here are going to tell you about how we can make difference in the lives of children with thalassemia major or thalassemia intermedia, which is kind of midway between the carrier status and the major, and make an impact in their lives. And that impact can only come when all of you work with us to give them a good quality of life. So we have very esteemed panelists, and they have been introduced. And I'll start off right from our doyen. She has worked with thalassemia so much from the government side that, whenever we had any issue with thalassemia related matter, we used to look upon Vinita ma'am and ask her so many questions, and she was always very helpful and supportive to us. So, ma'am, my first question to you is that how is government, because nothing can be done without the will of government. How is government of India strengthening policies around treatment access, financial protection, support comprehensive thalassemia care?
Thank you. I was very happy to hear that people know about thalassemia now. Because if I remember 2010, there was less of awareness, and people were not even knowing what is thalassemia. And the children has to suffer, the parents has to suffer. If one child with thalassemia is born in family, the whole family has to. So this was the thought. And when we started working on thalassemia in government, it was in 2010. We started with working for giving free blood to thalassemia and sickle cell and hemophilia patients. And it was patients inside who has given us insight to the government that we need to have a policy for giving free blood to these three disorders. And the order was passed in 2010 itself by NBTC. Later on, because we were not having any prevention and specific guidelines on this, in 2014 it was well thought that now it is a time that we need to think, because there was a gap analysis which was done, that how much blood is being catered to which of the patients, and maximum catering was done to the thalassemia. So it was well thought that now it is a time that we need to get the guidelines for hemoglobinopathies, that is thalassemia and sickle cell disease. And where in 2016 it was, in 2015 it was prepared, and all credits to the senior officials of the Ministry of Health and Family Welfare. Blood cell was established. I was looking after blood cell only. And we came up with the hemoglobinopathies guidelines in 2016 January. And it's still January, it's a long now, it's more than 10 years that these guidelines been adopted in the states. And during our implementation, this PIP, these proposals were created from the states for the prevention, management, and the other issues which comes up during the treatment were taken care. So if you talk about these guidelines are the comprehensive guidelines which talks about the prevention, management, and treatment both all together. The best part was that we started working for other things also, because for us, it was not only the guidelines which were going to help us. We thought of having a bone marrow transplant or strategy also, which was very important for us. So we came up with the Thalassemia Bal Seva Yojana with the Coal India, and this has reduced the cost of bone marrow transplant to 10 lakh rupees. Earlier, I mean, in many hospitals it was 15 lakh, but if you see, we identified on 6 centers initially, and now I mean, if you see these work of this Thalassemia Bal Seva, it has increased a lot, and it's one of the best practices across the world. I should say like that. Now, coming to screening, which was very important. The screening, which was already there in the guidelines, but there was constraint in the states that they were not ready for the screening, and there was a lot of myths. So we started doing a good IC with these states. A specific budget was provided to the states for the IC, and we started working on the IC activities. IC was information education in different parts and in different languages, and in different regional languages as well as in tribal languages, because I have been in tribal affairs also as advisor. So all these things were kept together, and then we started for the prevention, and we wanted that people should come voluntary for the screening.
So
We started with the screening.
these are very important measures, ma'am. Thank you so much. Because you know how madam highlighted that, we could do prevention, we could do transplant, and ma'am said 10 lakh rupees, 10 lakh rupees government is providing to do a thalassemia transplant. Madam talked about safe blood transfusion, and madam talked about guidelines. So, if all these things are set and government is working with you, how good, the impact of these policies can be to the outcomes and management of patients with thalassemia. So that's really incredible, ma'am. And thanks to people like you who have been involved right from the grassroots to help patients with thalassemia.
But one thing, Manas, I would also like to emphasize here that now we have packages in Ayushman Bharat, where the person can have treatment in the government as well as in the private facilities. And there's a treatment is full treatment is there. So you can have those treatments over there in public as well as in private. So totally, if you see, the government has taken many initiatives to come up with the thalassemia management, prevention, and also for the control. Thank you
So,
so much.
without government's will and, support, making a change is very difficult. So, thanks to the government of India who is thinking about thalassemia patients, sickle cell anemia patients, and making a huge impact in the lives of these patients. Now I come to Shobha Tuli ma'am. So like, the question was, आपने thalassemia के बारे में सुना है? Same way, there is no thalassemia patient in this country who would not have heard of madam's name. Madam is like a mother figure for every thalassemia patient. And I personally feel that every healthcare worker who is involved with the lives of thalassemia patient, madam has been a mother figure for them as well. With her nice and calm nature and with her assertive attitude, she has made a huge impact onto the lives of children and adults with thalassemia. Ma'am, my question to you is, you have spent your life working for thalassemia patients. And NGOs and civil society has made such a huge, contribution to improving the status of thalassemia patients. So my question is, what are the real world challenges you still feel that these patients are facing in our country? And how can patient organizations like yours bridge this gap in care, awareness, and long-term support of thalassemia patients?
Right. That trans-
No. So thank you, Manas, for bringing this question. And the biggest challenge I feel from the patients and parents side is the blood availability. As you know that they have to undertake blood transfusions each month, and that is for their survival. So it has to be the safe blood on demand without replacement, has to be fully tested, ideally NAT tested and leukodepleted, ideally again pre-storage filtered blood. So that is the biggest challenge. The another is, in spite of whatever the support is being given by the state governments through the union government, most of a majority of our patients, I would say about 70 to 80% of our patients living in this country are paying from their pockets. So it is the out of the pocket expenses which is another challenge for them, because they have, in order to give the recommended treatment, they have to buy the medicines, and the treatment is very expensive. About 1 lakh, it can go up to 3 lakh also per patient per year. Another challenge I feel is, in spite of having the packages, which Madam is here, and NHA and Ministry of Health, and I was also involved into that. In spite of having those packages, the biggest challenge again is whether they are being used. Are they, the eligibility criteria is so difficult that so this needs a revision. And apart from that, another is that we will talk about that, but we have the RPWD Act in place. In spite of having that act, the inclusion and the adoptability is another bigger challenge. And what I feel is that the lack of awareness in our country, that's not for the patients, that's for the public, in order to more about thalassemia, that's the biggest.
Thank you, ma'am. And I think, one big challenge is also that we are not able to really prevent the births. Still, there are so many children who are being born despite awareness. And do you think that is also a big challenge and we are going to fight it out in the next few years?
I think it's another big challenge, and prevention is the key, because we have to make our government, and I'm very happy that the sickle cell elimination program is in place and it's running very smoothly. But it's time now, because since it's a preventable blood disorder, so prevention is the key to the good healthcare system in our country. And that will also, take away the burden of the blood that we have been used by the existing thalassemia patients, as well as the burden on the government health systems, because it is an expensive treatment. And I would like to mention here is that the NGOs, they have played an important role as far as the awareness is concerned. So whatever, I'm very happy to know it here in the hall, each one of you knew about thalassemia. So it's I think the credit goes first of all to the thalassemia NGOs. They have done a lot of good work in their state governments, but still there is a huge gap, and we need the hand holding from the corporates, from the state governments, from the government of India, that this prevention program should be in place to prevent the future birth of children with thalassemia major.
Absolutely, ma'am. Thank you for those words. Dr. Sangeeta, uh, you are the person whom we need on a day-to-day basis, because we need to give blood to these patients. They will walk in happy. Really speaking, an adult thalassemic walks into the thalassemia unit with her or his boyfriend, girlfriend, or maybe their spouse, and come for blood every month. And they may need 4 units of blood in a month. So it's a huge burden. How do we provide safe blood, good quality blood to these patients? Because blood is their lifeline. There is no life without blood for these patients. How, from the transfusion medicine point of view, your department or the country, how can we make sure that patients get good quality blood?
This is very important aspect that these patients deserve to be transfused with safe blood. Now the safety comes from the donor. So when we are talking about the blood components need to be prepared in they need to be collected from the safe donor. The components need to be processed, then tested, then issued in a licensed blood center, and not just anywhere. We keep on reading in newspapers that somewhere something so happened. So the regulatory control over the place where blood components are being prepared is very important. Now, when we are talking about collection, the first and foremost thing is, where is this blood coming from? We do not get it from factories. So it is very important that the donor is a voluntary, non-remunerated, safe donor, and we are not collecting blood from professional donors or people who have high-risk behavior history. Then when we come about testing, it is very important that the blood that we are giving to our patients is not transmitting infections like HIV or hepatitis B to our patients. So apart from the regular tests like ELISA or CLIA, which should be done robustly in a proper manner, and there is also the newer tests like NAT tests, which need to be incorporated, which is not yet fully incorporated in our blood transfusion services in India. Then processing and issue of blood has to be done as per the stringent quality requirements in a controlled environment where adverse transfusion reactions can be properly monitored. Then the type of components, Mrs. Tuli has already said about it, that rather than whole blood, we should be giving them the packed cells, and they should be leukoreduced for prevention of complications.
So that's very important, and I think an appeal to all of you here that please donate blood, because your donation really matters to these patients, because once you donate blood, it saves one person's life. And young people are the best to donate blood. Your blood is, hemoglobin is good, full of energy, full of positivity, free of disease, and that is what makes the difference in their lives. So, Ritika ma'am, it's now known that if you have a matched sibling, अगर किसी थैलेसीमिया मेजर के बच्चे का भाई बहन है, मैच सिबलिंग है, जो HLA टाइपिंग से मैच मिल गया, उससे उसका ट्रांसप्लांट करना चाहिए. Why? Because this transplant can stop the requirement of blood. So this is a known fact, ma'am, and we all recommend. But nowadays there is a lot of talk about haploidentical transplant. Why? Because only 20 to 30% of children with thalassemia will have a matched sibling donor. That means 70% will not have a matched sibling donor. So ma'am, what's your opinion about this half-matched transplant from the parents or the sibling? Because if you are able to do a good, safe half-matched transplant, virtually everybody has a donor. So donor problem is gone. What's your opinion on that?
Absolutely, Dr. Manas. So by now, I think everybody understands that the pivot of treatment so far has been transfusion, and long-term transfusion leads to iron accumulation, and in the end requiring chelation. So transfusion and chelation is what we say is the pivot of management of thalassemia. But it is not an ideal situation because it does not help improve the quality of life of our patients. And as Dr. Manas said, that a transplant is something that is the only potential cure that we can offer to our patients. And of course, the gold standard will always remain a matched sibling donor transplant. But as you said, it's only present in 20 to 30%. Look for an unrelated matched transplant. We need really look for a donor, and it's ages before we are able to find one. So of course, a haplo or a half matched transplant does seem to be the forthright answer, because invariably the individual would have a parent or a sibling who would be willing to donate a transplant. So of course, I mean, it's easier said than done, because even with a haplo, the 20% matches are seen, and the risk of complication is high, costs are exorbitant. But when we have our policymakers, we have people like me supporting the transplant programs, I'm sure the cost should not be inhibitive. And when we compare it to the cost of lifelong transfusion and chelation and multiple visits and the complications, I'm sure costs would probably be comparable. And age is another factor that we probably need to look into, that the younger, the better, because the burden of iron is low and more likely to go into, gives better outcomes and better results. So definitely, I think it is a critical bridge to cure in transplant right now. So I think we really need to invest in haplo.
So, as the transplant medicine, the science of transplant medicine is improving, we are getting better and better with every passing day. The outcomes are improving. 10 years back, 15 years back, we were very hesitant in talking about haplotransplant. But nowadays, the technology has improved, the supportive care has improved. The cost still is very high, and it cannot be just, a government policy to just support every haplotransplant. But I think centers with expertise, where they have confidence, where they have done many more haplotransplant for say cancers and for other conditions, this technology is being used to cure many patients with this condition. My next question is to Dr. Dinesh. So there is a lot of talk of many drugs which can bring down the transfusion requirement. That's very attractive. You see, there is a drug called thalidomide. It's very cheap. And if that works for you and you don't need blood, you don't need transplant, you don't need chelation, what a wonderful thing that can be for a thalassemic patient. Similarly, some newer drugs also have come, like luspatercept, mitapivat. I want your comment on these drugs. And should every thalassemic child be hopeful that, now their requirement for transfusion is just going to suddenly stop because these drugs are now available?
So thank you very much for the question. The best treatment for thalassemia as of today remains bone marrow transplant. But besides that, majority of our patients are actually only living on blood transfusion. Unfortunately, transfusion is not always safe, and even if we are using a safe blood, all patients land up in some problem because of iron overload due to multiple transfusions. And unfortunately, many a times the whole body gives up because of multiple transfusions. So if I can avoid transfusion, that would be also a good strategy to maintain quality of life of the patient. So fortunately today, there are a lot of drugs available which can increase uh, the life of a red blood cell, which can increase the manufacturing of the red blood cells, which can decrease the destruction of the red blood cells. And fortunately, such drugs are available. Why are they then not being used? So we have to really go into these details and try to resolve this issue. Naturally, the foremost cost of few drugs which have been recently introduced is cost. Like one drug introduced last month in America, $30,000 a month. Definitely, I don't think that we can really have that drug in India. But at the same time, the drug is so simple that I am confident that my pharma industry will be easily able to manufacture it because it's a basic chemical molecule. I don't know how to proceed with this, but I think government should come up with a strong regulation. Fortunately, in last 2 months, two court judgments have come in the favor of manufacturing drugs in India and giving away with the patents. So, if something can be done to manufacture cost, would be the solution. Both the two drugs which really can help thalassemics, as Dr. Alra just said, mitapivat, luspatercept, they can be and should be manufactured in India, changing regulation. The other two drugs which doctor mentioned, like Dr. thalidomide or hydroxyurea or thalidomide azacitidine, these drugs are available in the country. But unfortunately, they are not used with all thalassemia. So what I would like to is the medical agencies with the NGOs should sit together and try to define a guideline of usage of these two drugs. I principally believe that if there is a good guideline to use these drugs, I think we will be able to reduce the number of transfusion requirements and henceforth reduce the burden on blood banks and increase the quality. So I feel the medical associations and the NGOs should come together to clearly define the guideline for the usage of thalidomide and hydroxyurea. This could be our first.
Thank you, sir. The issue with us, what has been is that, we have not really been able to identify who are the thalassemics who will benefit from these drugs. So as the research goes on and, these drugs are being now used, for so many patients, and we are able to identify that this particular mutation, this particular type, this particular polymorphism, this drug will work, we'll be smarter to use these drugs safely for these patients. And also we are, kind of little bit worried about the side effects as well. So we need more and more data to kind of routinely prescribe them. Shobha ma'am, the next question is about the Thalassemia Bal Seva Yojana. How is this Yojana going in India? And what is the message for a patient with thalassemia major? Should they just go and try to get a transplant done? What is your message, and how is this success of this program going?
Thalassemia Bal Seva Yojana is an initiative of Coal India, and which was, of course, with the help of Ministry of Health, Family Welfare, and Madam was there as an consultant there in the ministry. And I would say, as she has already mentioned, this Yojana and this scheme has been talked about in various forums worldwide. So I feel very proud when this program or this project is being discussed in the open international forums where India is appreciated for coming up because it has come from a corporate under this CSR scheme. So under this scheme project, which was initiated in 2017, and it's 8 years now, so 915 bone marrow transplants are being done for the mass sibling donors as well as the thalassemia mud. And they've
big round
also
of applause, because 915 transplants in India, where 10 lakh given by Coal India. I think that's a very big achievement.
So this includes the number of aplastic anemia also. Started from when this was initiated 2017, 4 hospitals were empaneled. Now we have 21 hospitals empaneled by the Ministry of Health spread all across the country. Expert committee members, 8, who are the experts in their own way on this subject. And all the meetings are held under the auspices of, under the chairmanship of JS Policy, Ministry of Health and Family Welfare. And I'm very happy to share and humbled really that Thalassemics India has been appointed as the coordinator to run this program countrywide since then. This scheme is going to finish, this third phase is going to finish in April, by April 2026 this year. So we are keeping our fingers crossed that it will enter into the 4th phase with the support of Coal India.
Thank you, ma'am. Vinita ma'am, next question is for you. There has been this resonating theme of preventing thalassemia. What can be done at the national level to prevent the birth of a thalassemic child?
Maximum information to the people, the school education, the college education, and every youth should know that they have to get them tested before they get married. रक्त कुंडली से जल्दी मिलाइए, जन कुंडली से पहले रक्त कुंडली पे ध्यान दीजिए, उस पे ज़्यादा फोकस करना होगा.
Dinesh sir wanted to comment.
For the audience sitting here and in the metro, probably this thing can be really made very, very easy. Everybody is insured today. Everybody has a mediclaim. And majority of the people going for pregnancy and for childbirth, majority of them insured. So we have to insist on the insurance companies and the people who are getting insured that there should be a definite genetic disorder checkup for every young family who is likely to have a child. Especially when somebody gets pregnant, every pregnant woman should have a blood testing.
That's a
and
very good thought, sir.
But this
the-
is happening in the
No,
world.
That's a very good thought, but the problem is that in India, number of people who are insured are 5%.
So that is
95%
why it's
don't have an
only the
insurance.
school education,
Yeah.
college education, and the awareness in a
Education,
sense
yes.
which will be helpful. And once everybody knows about their
True.
status, it will be easier for us to prevent the disease and prevent the birth of the new children.
True.
Thank you.
Sangeeta ma'am, comment from you about stem cell donation. आप सब कोई भी आपने दात्री का नाम सुना है? Datri is a stem cell registry in India. If you become enrolled with Datri, you are like a blood donor, a bone marrow donor, stem cell donor. So, there is no awareness. That is why we don't find unrelated donor. Sangeeta ma'am, what is your appeal to the audience?
So it's as has already been discussed that the transplant is the only cure for this. Previously, we used to have bone marrow transplants which were painful, invasive. But now we have the stem cell transplant from the peripheral blood, which is very easy procedure. You're just hooked on to a machine, and it is like any other blood donation. A little bit longer, a little bit more complex, but it is very safe, not at all painful. So we, like for voluntary blood donation, I appeal to all of you that register yourself as stem cell or bone marrow donor in all these registries like Datri, and there are few other registries which are there in India, because these patients need these, and it is not going to come at any expense to you. These registries are going to take care of all the expenses, and it is very less painful, not invasive, and we really need to do it. It is more altruistic than any other acts that you are doing.
That's right. तो अगर आपने किसी को बोन मैरो या स्टेम सेल का दान दिया, उससे बड़ा और कोई दान नहीं हो सकता, because you can save the life of that person. Ritika ma'am, just we are about to finish. One couple of questions to Dr. Ritika and then Dr. Dinesh. That adult thalassemic, you have worked so much, ma'am, for the transition of care for pediatric to adult thalassemic, and ma'am leads the work in her hospital. So is it a big challenge for transition of care for these patients from pediatric to adult?
Yeah, so transitioning from pediatric to adult is a critical step in the management of thalassemics. Because the team changes completely, and during pediatric and adult care, and this it is definitely a big challenge. But I think more than a decade now it's been transitioning from pediatric to adult care at our center, and we have almost more than 300 patients who are enrolled with us who have transitioned from pediatric to adult care, and I'm happy to say that now it's so smooth that that when they are enrolled in pediatric care, they are already aware that they are going to come to us next. So I would again request adult care physicians not look at thalassemia as a pediatric illness anymore, because it is as much ours as it is theirs.
Thank
So-
you, ma'am. Thank you. And very important is that when they become adults, sometimes they forget taking their medicines and they don't take their chelation. And then the iron overload becomes too much, because when they were young, their mothers were making sure
Yeah.
that they are taking their medicine. And that is why compliance is very important. So big appeal to patients that please don't forget taking your iron chelation, because iron overload is the big killer. We don't want children and adults to have iron overload, and there are good drugs, oral drugs available that can prevent iron overload. Sir, monitoring of these patients, this is just the last question. So, like, you have cancer, you are treated, you are cured, you are in the community. Sometimes you forget going to the doctor, it's fine. You had a bad infection, you forget about the doctor after you are cured, that's fine. But can thalassemic not be connected to the healthcare expert for the rest of their life, or do they need lifelong support?
They definitely need a lifelong support, and unless we create a system of care and a system of empowerment, this would never happen. So my humble request to all the NGOs and thalassemics working together, that we have to create a system. Fortunately, majority of the tests required for follow-up are already covered under Ayushman Bharat. And majority of the children I have seen with thalassemia and as well as sickle, all of them carry Ayushman card. So care and investigation today should not be at all a challenge in this country. We have to only create a small system of healthcare empowerment. I have already done it in cancer care. It's very easy to do. It is doable, and potentially every thalassemics can follow a strict follow-up schedule, which you can design as an expert, and that follow-up can be done in government district hospitals. So unless we make government district hospital as a basis of care, and one medical officer from this department of government medical officer in charge of all thalassemics of the district, we will not be able to achieve anything. But if we just create the small system, district hospital in charge, one district medical officer in charge, all investigations already available free under Ayushman Bharat, the follow-up is definitely not a challenge.
Thank you, sir. Thank you so much. So I work at Gangaram Hospital, and we have a Preeti Tuli Thalassemia unit where we give care to thalassemia patient right from birth to, their end of life. So, it's a full spectrum, and we look after children, adults, and, it's a lifelong care, and they live a very good quality of life if, the physicians, the parents, the patients, the NGOs, the government, all of us come together, because it takes a village to look after a child or an adult with thalassemia. And I think awareness, the will, and your participation in this whole discussion today kind of highlights that the thalassemia patient is going to live a very good life in the years to come. Thank you very much to all the panelists who have come here, and hope we have communicated some important messages to our audience. Thank you very much. Thank you.
Thank you so much, sir. Thank you so much for excellently moderating. And I think conversations like these are essential in strengthening systems and ensuring better outcomes for patients and families. Now, I would like to request Dr. Manas Kalira to please come on center of stage to facilitate the co-panelist, Dr. Vanita Srivastava. And audience, let's have a round of applause for this amazing session. I think that's why this was a spotlight session, a need of the hour and timely discussion we had. Mrs. Shobha Tuli. Dr. Sangeeta Pahuja. Dr. Dinesh Pendharkar. Dr. Ritika Sood. Now I request the panelists to please come on center of stage for a group picture.
Just I'm repeating that I would like to thank Voice of Healthcare for keeping this special session on a subject, thalassemia, which is so close to our hearts. Thank you.
Now I would like to invite Mr. Rajiv Nath to please come on stage and felicitate our moderator. Dr. Manas Kalra. Let's have a group picture now. Thank you everyone. Thank you so much. So with this, we'll move on to our next session. But before that, as I said, that we always keep you engaged. So I have my next question ready with me. Are you all ready with your answers? Are you all ready with your answers? And you just have to quickly raise your hand, okay? So next question on the screen is, can we have the question? Which authority regulates blood banks in India? We have option A, ICMR, B, CDSCO, C, Niti Aayog, and D, NAB, NABH. Rajiv sir, I know that, I believe we all know कि आपको ये सारे answers आते होंगे. Yes. So yes. B. Okay. Can we any more guesses? CH. Okay. Can we have the answer on screen? It is CDSO, and we got the first right answer from the lady sitting in front. Congratulations. Okay, so we'll have another question on screen. Which scheme promotes domestic manufacturing of medical devices in India? Rajiv sir will definitely know this, but we'll come for the explanation of this answer with you. Okay, I'll go to the person sitting here. More guesses? Startup India. Okay.
Hello.
Skill India. Okay. Can we have the right answer on screen? It is PLI scheme. I think let's have a round of applause for sir. Now I'll come to Rajiv sir. If you could just give us a fact about PLI scheme India. That will enlighten us. That will enlighten our audience about.
So the scheme for PLI under medical devices was by department. The production link incentive scheme for medical devices was introduced by the Department of Pharmaceuticals. This was a 3,200 plus crore scheme, which basically looked at 4 specialized area in cardiology, in imaging, and couple of other areas. So I think it's till now galloping, but it needs to take a faster pace.
Thank you so much, sir, for that information. Now, with this, we'll move on to our next segment, which is a keynote address. So, India's medical device sector is at a defining moment with growing global opportunities, strong policy momentum, and an increasing focus on quality, innovation, and exports. To share a valuable insight on this journey, India's positioning on global healthcare map, we are honored to have a distinguished industry leader with us today. It's my privilege to invite Mr. Praveen Mittal, Executive Director, Export Promotion Council for Medical Devices, to deliver the keynote address. May I have a round of applause for him?
So very good afternoon, and thank you for giving us the opportunity to be here today. I represent the Export Promotion Council for Medical Devices. It is a Government of India agency, and we have a short presentation, and we'll be happy to answer any of your questions. Can I request you to... So as you see, we were established by the Department of Pharmaceuticals in the year 2023, but we became actually operational in year 2024, September month. It is being driven by the bylaws of the Export Promotion Councils formed by Commerce Ministry. It is a partnership organization between Department of Pharmaceuticals and the Yamuna Express Industrial Development Authority, where our office is located as of now. Why Yamuna Express Industrial Development Authority? Because Government of India, as you heard about the PLI scheme, which is the Production Linked Incentive Scheme, apart from that scheme, the Government of India also came up with 3 medical devices parks to promote domestic manufacturing, not just for domestic consumption, but also exports to global geographies, and also looked at it as an import substitution. So with that as the objective, the 3 medical devices parks were established. One up north, which is being, taken forward by YEDA and Uttar Pradesh, which is coming just about 3 kilometers away from the Jewar International Airport. One came up in mid of our country, which is Madhya Pradesh, at Ujjain, and one we have down south at Kanchipuram in Tamil Nadu. So as I shared with you, this is a strategic bridge. As an export promotion council, we work very closely with our Indian manufacturers, and of course, looking at exploring international markets so that our Indian-made products can actually reach the global geographies. We are looking at it as the India's agency to promote Indian manufacturing. While I speak, we are about a 180 plus member driven organization with our lifelong members like Ellingers, Wiproji, Polymed and Romsons. So what does an export promotion council does as an objective, or what is our role? So as I shared with you, our primary objective is to promote the Indian-made products to global geographies. Then also we work on behalf of our companies or the members, the Indian companies, to liaise with the government on policy. We also provide market intelligence. So in case if you were to log into our website, which is www.epcmd.in, you will start seeing various country dossiers in the knowledge section, where you get to know the disease profile of various countries, and we're building on that in terms of even export-import data, which month, what was our export to various regions, top 20 countries where we are exporting, top 20 countries from where we are importing, if our exports is going up, if our imports is getting more. So all that data analysis is being done by us through the DGCIS data, the raw data that comes to us. So we also provide you with that market intelligence. We, as a Government of India body, promote participation into trade fairs, which is within India as well as globally. So our members, in case if we were participating formally, we would subsidize the cost of participation. We organize buyer-seller meet. One such buyer-seller meet was organized in September 2025 from the 4th to the 6th at same venue, Bharat Mandapam, where we had staged the India MedTech Expo. And we had invited almost about 123 foreign buyers from about 33 countries. So they gave an opportunity for the companies to interact and engage into B2B engagements. We also believe in doing capacity building. So we do regular webinars and workshops and seminars. We are responsible for promoting brand medical devices, image of the country in the global markets. And of course, we encourage the compliance, adhering to the international standards so that our products are globally acceptable. These are a couple of tasks that we keep doing. I have already spoken about this. I spoke about the exhibition support, the global networking opportunities, of course, policy advocacy. We are responsible for, of course, knowledge enhancement and capacity building. I shared with you the kind of information that we keep coming up on our website. Kindly keep visiting the website. That would give you a lot of information and insight. We have been organizing webinars with the experts and, of course, the regulator. There's such, some glimpses of such webinars that have been organized in past. In fact, the next one we are planning to do shortly on the compliance along with one of our experts from IPC. I spoke about MedTech Expo, the last one which was organized from 4th to the 6th of September. So we're looking at you becoming a part of our Export Promotion Council for Medical Devices. These are a couple of financial benefits. We also give you, with Commerce Ministry, the ROTTAP, benefits that you get, you can process them through us. Under MAI scheme, we also support participation into various exhibitions and fairs. So in case if you are willing to look at export markets, please feel free to reach out to us. Couple of important companies which are a part of our membership. We want to develop domestic champions. That's the idea, the way the pharma moved. PharmExcel was formed about 24 years back. We are on a similar journey, but what they covered in 24 years, we need to, make fast movements on this so that the medical devices sector is known globally for the products that we manufacture here. I already spoke about the 3 medical devices parks which are supported by Government of India. These are our contact details. I look after the organization along with my colleagues who are responsible for membership and events, then government coordination, and of course, the regulatory and technical compliance. So I think with this, can stop sharing the presentation. We are here to support our Indian manufacturers whichever way we can, and please feel free to reach out to us. Thank you so much for giving us this opportunity.